Hi, everybody, and welcome to this edition of the Taking Control of Your Diabetes podcast. I am one of your hosts, Dr. Jeremy Pettus, joined as always by my good friend and colleague,
Dr. Steve Edelman.
And we just keep seeing how long I can make that pause. It's pretty fun. But if you're just tuning in, Steve and I were diagnosed with type 1 when we were 15. We are endocrinologists at the University of California, San Diego, and of course work for the fantastic not-for-profit organization Taking Control of Your Diabetes. We enjoy putting on this podcast, and we have I think always good topics, but I like this topic as well. This is on chronic kidney disease, what we call CKD or kidney disease, in people specifically with type 1 diabetes. However, essentially a lot of what we're going to say is relevant to anybody with diabetes and kidney disease. So Steve, tell us why this topic?
Well, this topic is near and dear to my heart. As you know, Jeremy, I've had type 1 over 50 years, and when I first got diagnosed, it was a time when they didn't even push glycemic control. I'll spare you all my caveman days, but I do have CKD myself. Mm-hmm. I have CKD stage 3, which we'll get into. And so I have tried to educate myself. I see a kidney specialist, and I'm on top of all my patients. And it's all about prevention. Mm-hmm. And I'll say this, and I've said it for 25 years at our face-to-face conferences. There are no symptoms of early diabetic kidney disease. And that's important to know, because you could be going along happy, and then all of a sudden your doctor says to you, hey, you got some serious kidney issues going on. And that's why yearly screening is important, and we'll talk about that.
Yeah. And anybody living with diabetes, knows about complications. This is kind of maybe the dreaded gorilla in the room, I guess, that we probably don't talk about enough. And I would say the three microvascular complications that usually come up are eye disease. That's why we're always going to the eye doctor. We talk about nerve disease, neuropathy, and then of course, kidney disease.
Yep.
So Steve, do we know why high blood sugars or diabetes causes kidney problems?
Well, there's a lot we don't know, but the commonality is high blood sugars causing damage to the microvasculature that delivers blood to the different organs, our nerves, our kidneys, and our eyes. And if you don't get enough blood, then you get fibrosis and you get damage. Let's talk specifically about the kidneys and to the little nephrons that are the important filtering part of our kidneys. And that's why when we get to the test order, we'll talk about the glomerular filtration rate. And we look at things like fibrotic levels and things like that. So we don't really know, but high blood sugar causes damage to the microvascular. And one thing we teach the younger doctors all the time is that if someone has serious eye disease like retinopathy, you better be looking for kidney disease and vice versa, because they do go in parallel.
Right. And I've heard people say that, we think of diabetes as a blood sugar disease, but what it really is a vascular disease. It affects these small little blood vessels that get blood and nutrients and everything to these very important parts of our body. And when blood sugars are high for a long time through various reasons that we don't honestly understand all the reasons why this happens, but you can get into issues with kidney problems. So how common is, kidney disease in people with type 1 diabetes? And there's, publications that look into this. There's national health databases. There's something called the NHANES database of people that live in the United States. And the recent data is that of all the type 1s in the U.S., about 20% of them have some form of diabetic kidney disease. And as we're going to talk about, that's a big spectrum. That could be people that have no real issues at all the way to people on dialysis. And people might have different opinions on that. If you kind of thought to yourself, how many people in the United States would have issues, I bet some people listening would think, I bet 90% of people have it. I think there can be this concept that people think, I'm just going to get it at some point. But a lot of people do live their whole life without kidney disease. And even people like yourself, Steve, that do have some kidney problems, once identified, it can be, yours has been thankfully stable, knock on woods. People can still live very well with this. So it's not doom and gloom, but here are the statistics.
Yeah, and there's probably a lot out there that are undiagnosed, who don't get regular healthcare visits. And glucose control is just so important, because we know from that ancient study, the Diabetes Control and Complications trial, that there's a direct correlation with A1C and the incidence of diabetic kidney disease, along with retinopathy and nerve disease. And they took the data from the DCCT, very interesting, because people pricked their fingers a lot, and they turned it in to the study coordinators, and then they went back and looked at time and range, because they didn't have CGMs back then during that study, and they showed a direct correlation with time and range as well. So we use time and range a lot these days, and that's a good metric to indicate if you're at risk for these microvascular complications.
Yeah, and that's something we're talking about a little bit, is that our A1C goal of 7 came from that study. And they found that basically any improvement in your blood sugars mattered in terms of reducing kidney disease, eye disease. But it mattered a lot more at kind of the high A1Cs. Like if you went from 11 to 10, that's a big improvement, 10 to 9, 9 to 8. But as soon as you got down to 7, going from 7 to 6, certainly to 5, didn't really matter that much in terms of reducing long-term complications of kidney and eye disease. And that's important for our listeners out there that are saying, I want to be normal. I want my blood sugar A1C to be 5.5. And you can end up with a ton of lows all the time without really any benefit in terms of reducing these complications. So that number of 7 came from a lot of this data.
Yeah, it's important to note because a lot of people are misinformed, and even their doctor says, oh, you get your lab slip and there's like a big red mark because your A1C is 6.7.
Right.
Like, they should have 2 columns, one for people who do not have diabetes and one for those that do. But, one of these days they'll change it, but it does scare people.
You're right. It's flagged because it's abnormal for somebody, who doesn't have diabetes. But it doesn't mean that should be your goal to be kind of quote unquote normal. I know, Steve, you've been striving to be normal for a long time and it hasn't worked out for you. So, all right. So you're listening. How do I know if I have kidney disease? How often should I be screened? And really, at least once a year, everybody with diabetes should have these 2 tests done. They're very common. Hopefully, if you're seeing any kind of primary care doctor that knows what they're doing, or certainly an endocrinologist, these 2 tests are very common. So one is a blood test. And from that blood test, it calculates your estimated, or your eGFR. What does that mean? Your estimated glomerular filtration rate. Basically, how well your kidney is working. How much are they filtering? And essentially, the higher the number is, the better. And we'll talk more detail about that test, the eGFR. And that GFR is really calculated mostly from your creatinine level. And there's an inverse relationship there, that the higher your creatinine level is, a normal creatinine is around 1, but as you go up from 1 to 1.5 to 2 to 3, your GFR goes down. So the higher your creatinine is, generally the worse it is, and gives you a lower GFR. Does that make sense?
Yeah, Jeremy, that's really important. And from those 2 values, they should calculate the UACR, urine albumin, which
that's
is
the other test. So this is the blood test, talking about the GFR. And then, yes, the second test would be the urine test that we're going to talk about.
Yeah, thanks for clarifying that. Is the urine albumin to creatinine ratio. Super important test. And that indicates more of the level of fibrosis in your kidneys. And if you go see a kidney doctor, which I do, they look primarily at the eGFR and the urine albumin to creatinine ratio, and they plot that over time. Mm-hmm. And there's a famous graph that graphs one against the other, and then it does predictions of how long you have until you will need dialysis. And the whole purpose of this podcast and many other videos we do is to delay the need for transplantation or dialysis. And diabetic kidney disease is preventable, and if you already have it, you can slow it down. These tests are crucial, and many doctors may not know that, and you have to ask.
Right. All right. So you get your your test results back, and I went into my chart. That's a system we have at UCSD for my own blood tests. And, it gives you an eGFR, and usually the cutoff is like above 60. It'll say above 60, and it doesn't go into much detail beyond that. But then lower than 60, it'll start actually giving you numbers. So in general, above 60 is normal. But as soon as you get to the 30 to 60 range, we call that stage 3, chronic kidney disease. And from 15 to 30 is stage 4, and then less than 15 is stage 5. So you might see this in your chart also. I have stage 3 kidney disease, stage 4, stage 5. What does that mean? Well, like you said, The lower you get, is more into that you need dialysis, you might need a kidney transplant. As soon as you get into stage 4, that 15 to 30 range, is when you should be having those complications. Absolutely be seeing a kidney doctor, a nephrologist, to talk about dialysis, kidney transplants, things like that.
Yeah, most kidney doctors will say, I wish their patients were referred earlier. And it's kind of weird, these stages, but 60 to 90 is stage 1.
Yeah.
And a lot of labs, like you said, like UCSD, they just give you above 60. Some labs will give you a specific number, which I like better. But the minute your doctor says, hey, your eGFR has been dropping, even if it's not in any danger zone, please go see a kidney specialist, because they know a lot more of the ways to prevent you from progressing. And they start measuring other things like phosphate and potassium and other hormones from your brain, PTH, and they get a much better feel of where you are on the spectrum of reaching dialysis or transplantation.
Now, this GFR, another quick caveat about it is that it can oscillate depending on how hydrated you are, things like that. So if you get one blip, make sure you repeat it, make sure you're hydrated. That's important to get like an accurate assessment. So that's the first test. It's a very simple blood test. Basically, your creatinine gives your eGFR. It can put you into these different categories of chronic kidney disease. Hopefully you don't have it, but if you do, this is stages.
Yeah, just say real quickly that most people get a chemistry panel before their doctor visit once a year. And those are 2 standard values.
Right.
And so you just need to look at them. I remember one year I texted Jeremy, I was all depressed because my eGFR was down. And he says, do it again and go drink a shit ton of water. And I did, and it was back up to the normal level. And man, he saved my level of depression for that day. Because you know what? Being a type 1, I certainly don't want to be on dialysis.
Well, nobody does.
Yeah.
So, all right. So that's the blood test. The second one is the urine test. So basically what you need to know is that you should have a blood test. You should have a urine test. From the urine test, they will be able to calculate what they call your microalbumin to creatinine ratio. And these have different levels also. So less than 30 is normal. Between 30 and 300, we call microalbuminuria. I mean, you have a little bit of albumin, a little bit of protein in your urine. And above 300, we call macroalbuminuria. So you don't want any protein in your urine. And this one can be confusing because if you have absolutely 0 protein in your urine, a lot of times it'll be flagged as unable to calculate or even like a little exclamation mark by that. And that's a good thing because you have absolutely no protein in your urine and can't calculate it. So I get those messages from patients sometimes like, what does this mean? Why is this flagged as abnormal?
Yeah, the UACR is not just measuring albumin, it's the ratio that's important. And that measure is really an important feature of how well your kidneys are working as well. And I've heard kidney specialists say multiple times, if you're going to look at one test, it's the UACR, and that's the one that you really want to get down. And it relates the level of fibrosis. So it's not just protein; it's the protein divided by the creatinine, the albumin divided by the creatinine. So it's an important ratio, and that will come in your urine analysis, as you said. So the minute you ever get above 30, or even encroaching upon 30, like you see year after year, you're getting, from 5 to 10 to 15, 30, you should ask for a referral to a kidney doctor.
And an important point about this is that diabetic kidney disease, if the cause of your kidney disease is from diabetes, it almost always results in protein showing up in your urine. So if you have a case where for some reason your eGFR is going down, you're developing chronic kidney disease, but there's no protein in your urine, that could be from high blood pressure, other causes. So it's helpful in kind of discerning the cause a lot of the time. So let's get into treatment. And we're starting with these kind of pillars of treatment, and the interesting things about this is that these are things that are helpful in preventing kidney disease. And then if you do have them, you just, it's another reason to kind of be potentially more aggressive with them. But the treatment is kind of the same when we talk about preventing versus actually, treating kidney disease. In addition to when you actually, if you have kidney disease, you might add some extra medication. So let's talk about kind of the base of the pyramid of the that are important all around. And three things I would say really come up that are key. Is one, blood sugar control. We've talked about that kind of already. Getting your A1C down to less than 7, whether you have type 1 or type 2, that's critical. The second one we haven't mentioned as much is blood pressure control. So what do you recommend for blood pressure?
Yeah, I mean, first of all, a lot of people don't consider blood pressure related to your kidneys. They think it's your heart, but it turns out that it makes retinopathy worse as well as kidney. It's so important because if your blood pressure is high, your kidneys take on the brunt of high blood pressure, and there's nothing that knocks off your kidney faster than high blood pressure. So, the national recommendations have changed through the years, but I think being a diabetes specialist, I want my patients for sure less than 130 over 80. Everyone with diabetes, type 1 or type 2, should have their own blood pressure cuff at home. And don't just panic on one value. Your blood pressure changes like airline prices and rent-a-car availability. So you have to look at your blood pressure at different times of the day. And if it's good most of the time, then you're good. But you have to have your own blood pressure cuff because, once again, high blood pressure doesn't cause any symptoms. If you get a nosebleed, of course, you're 200 over 100. But you can walk around with high blood pressures, feel perfectly fine, and you're knocking off your kidneys, you're causing problems with your eyes and your heart.
Yeah. Well, we call this the ABCs of really diabetes management, which is for your heart, for your kidneys. So A, getting your A1C down, we talked about. B, blood pressure. C is for cholesterol. And like you said, the guidelines have changed, over the years. But it really has come down to this, to make it very simple, that if you have diabetes, certainly if you have type 2, and if you have type 1 and you're over 30, certainly over 40, you should be on a cholesterol lowering medication because we really want people's LDL now less than 70. And it's almost impossible to get that down, just by existing, or certainly with diet, exercise, things like that. So getting on a good cholesterol lowering medication, typically a statin, to keep your cholesterol down is so important.
No, I totally agree. And a lot of people don't put cholesterol with kidney disease, but it's important. And plus, you're going to get the benefits on your heart as well.
Absolutely.
What else is on that pyramid you're looking at, Jeremy?
Well, we have smoking cessation. And we were just talking about before we started that this is something I think we don't talk about enough at TCYD.
Because we're so high, we forget.
Well, we just, a lot of people are smoking less, which is a good thing. But certainly if you are smoking, there's probably nothing more important you could do for your heart and your kidneys than stopping, smoking. Exercise is important. Not going to go into details of that. Nutrition, this is where a nephrologist or a kidney doctor can be really helpful of, what is really key to helping your kidneys in particular when it comes to your nutrition. And salt intake comes up. I learned semi-recently that the main source of salt in our diet actually comes from bread. So things like that you might not know. It's not just, I'm not going to add salt to my eggs or whatever. What are kind of high salt foods that you could, avoid, for example?
Yeah, and I think diet's always important. And we don't want people to stop eating the things they like to eat, but it's good to learn. And if you do develop kidney disease, then dietary issues, restricting certain things are extremely important because your kidneys may not be able to filter them out. I think it's important to mention maybe at this point, besides foods, maybe some of the medications that we tell people to avoid because non-steroidal anti-inflammatories like Motrin, Naproxen, they're great anti-inflammatories. But if you take too many, if you take high doses over a intermediate to long period of time, it could seriously damage your kidneys. So, I try to send people to extra strength Tylenol, part of your aspirin a day to protect your heart as well. And for most people, they can take these drugs because they're important. They're used so often, but you have to keep that in the back of your mind. You can't overuse them.
Right. Okay. So the last thing I'll say about blood pressure and lipids is that I feel that they're very, very relatively easy to treat compared to blood sugars, especially with type 1, we spend all this time getting our blood sugars under control. But usually they'll say, blood pressure, cholesterol, worry about that at the next visit. And it gets kicked down the road for years and years and years. please, jump on that. Know these goals: 130 out of over 80 for your blood pressure. If you're not there, think about starting something. For your cholesterol management, really think about being on a statin, and not just saying, oh, I'll do better with my diet. Be a little bit aggressive about these things. Okay.
Yeah. Well, Jeremy, sorry I jumped ahead with the non-steroidal comment, but I should mention, since you're talking about blood pressure, well, 30 years ago, they came up with this new blood pressure pill called ACE inhibitors. Mm-hmm. Many of us are on it: Monopril, lisinopril. There's like 10 generic now, and they were proven to prevent the progression of diabetic kidney disease. So it's really what we call the first pillar of therapy when you're talking about medications. You covered a lot of important other pillars. So when you talk about what medications can you take, ACE inhibition is super important, mm-hmm. and it's probably the first drug prescribed for people with diabetes. And many insurance companies tell providers whether they have kidney disease or not, get them on it, and that's a good preventative move.
All right. So then the other thing that is coming up now is these SGLT inhibitors. These are medications that are now approved for treating people for type 2 diabetes, helping with their blood sugars, but also in terms of preventing kidney disease and actually heart failure in people with or without type 2 diabetes, which is fantastic. But where are we in the world of type 1 diabetes with these medications, Steve?
Yeah, well, it turns out that there's companies, and there's one company who's sponsoring this podcast, Lexicon, who is developing an SGLT inhibitor specifically for people with type 1 diabetes. So they have to get it approved. It's currently available for type 2s with congestive heart failure, and there may be other companies coming up with specific therapies for type 1. We do know that there are other medications, mechanism of action for type 2, but this is probably one of the most important therapies we can give someone to prevent the progression of diabetic kidney disease. And the FDA gave the companies that make the current SGLT inhibitors on the market not only the indication for diabetes and heart failure, but specifically for reducing the progression of diabetic kidney disease. And they are extremely effective, more effective than ACE inhibitors, as I spoke about a minute ago, but they work well together. Mm-hmm. And so it's a very exciting time. And Jeremy, you and I were at the FDA when sotagliflozin was being asked to be approved for type 1 diabetes. That's an SGLT inhibitor. And this was years and years ago. We didn't know the benefits on the heart and the kidney at that time. Mm-hmm. And you and I have been talking about it, having a beer, that if they had known these benefits, they would have looked at the risk-benefit ratio of preventing kidney disease versus a very low incidence of DKA, that they probably would have approved it back then. But the FDA is charged with protecting the public. That's their first, goal. And so you can't give them too hard of a time.
Yeah. So to be specific, these drugs, we talk about them all the time, fantastic medications, but they're not approved for people with type 1 diabetes, specifically because they increase the risk of diabetic ketoacidosis. So what we have going on now is that a huge cornerstone of our treatment of diabetic kidney disease is these medications that type 1s don't have access to. But it's becoming this weird gray area where they're not approved in type 1 diabetes to control blood sugars, but they are approved to treat diabetic kidney disease, or actually kidney disease, in people with or without diabetes. So what do we do with our type 1s that have diabetic kidney disease? Well, there's a push to, it's just to start using these medications maybe off-label, and then hopefully actually get the approved indication.
Yep. I think that's, it can't stress it enough how important this class of drugs is for preventing the progression of kidney disease. It'll be nice to have one that was studied and specifically targeting people with type 1.
Mm-hmm. And so, I think kind of in wrapping up, Steve, I don't know, maybe if there's anything else you want to say about your personal story that you've been dealing with, kind of monitoring your kidney function. I know it's nerve-wracking for you every time you get it checked, but thankfully, like I said, it has been stable. And from me as a slightly outside view, it's because you've been on top of your blood sugars, potentially more than ever with your continuous glucose monitor, your hybrid closed loop. You're able to achieve blood sugar control that you've never been able to do before, not just you, but a lot of people. And then I know you take multiple blood pressure medications and really aggressive with your cholesterol. And it seems, and you finally put down your Marlboro Reds, which you were smoking for so long.
Right.
But it's paid off in terms of keeping things for you stable.
Yeah, thank you. And you've always been a great support person for me. And my kidney doctor did put me on an SGLT inhibitor, and my UACR, that important number, went from well above 300 to about 35 over 2 years.
It was in the thousands, wasn't it? Your albumin creatinine ratio?
HIPAA. I'm trying not to get that high. I don't think it was thousands.
Okay.
But it was well above into the severe range. And so I feel like I've gotten a new lease on my kidney life and delay the need for dialysis. And I hope I never need that. And I want to know what blood type you are in case I need a kidney.
Okay. I'm F. Very super rare.
F. Well, I really appreciate everyone listening. Make sure that you like us, you follow us, and if you have any questions at all about your kidneys, please email me.
And as always, Steve, it's great doing these with you, and hope you all enjoyed it, and we'll see you at the next one.
Thanks, Jeremy.